Without further ado, let me introduce to you Dr. Cecilia Sorensen, who will be giving today's lecture, How Climate Change is Changing Women's Health, Health Security, and Human Rights. So Dr. Cecilia Sorensen is a physician investigator in climate change and health at the University of Colorado School of Medicine and School of Public Health. Following residency training at Denver Health, she became the inaugural Living Closer Foundation Fellow in Climate and Health Science Policy, based at the University of Colorado School of Medicine and the National Institute of Environmental Health Sciences. Dr. Sorensen has a broad range of expertise at the intersection of human health, environmental health, and social justice, spanning both domestic and international emergent health issues related to climate change, including heat stress and worker health in Guatemala, wildfires and healthcare utilization in the United States, the emergence of Zika virus in Ecuador following the earthquake of 2016, climate change in women's health in India, and mortality following Hurricane Maria in Puerto Rico. Translating this research into policy to build resilience in vulnerable communities is the focus of her work. To this end, she served as a health author for the U.S. 4th National Climate Assessment and serves as a technical advisor for the annual Lancet Countdown Climate and Health U.S. Policy Brief, which is actually where we got to meet this past year in Washington, D.C. at the launch of the 2019 U.S. Climate and Health Policy Brief. And I have posted a link to some of Dr. Sorensen's work in the chat box there, including her wonderful appendix to the brief, so you can access it from the link that's in the chat box. Additionally, she is a founding member of the Colorado chapter of Physicians for Social Responsibility, a member of the Colorado Consortium for Climate Change, and a scientific advisor for the Citizens Climate Lobby. So without further ado, Dr. Sorensen, we are lucky to have you.
Thanks so much. It's great to be here, and I'm so excited that this elective got organized. I know everyone is kind of sitting home, hunkered down right now, but I'm really glad that we can talk about issues that are so relevant to what's going on right now in the world. So today I'm going to be talking about how climate change is changing women's health, as well as impacting their security and human rights, both domestically and globally. I have no disclosures that are relevant. I think some of you might have heard some of the information that I'm going to present, but I believe that repetition kind of helps us learn things, and I look forward to your questions at the end of this. So to get started, I really feel like we're currently living in unprecedented times in so many ways. But in regards to climate change, it's said that we are the first generation to feel the impacts of climate change, and that we're the last generation that can really do anything about it. So as you've probably heard in the past couple lectures, over the past 30 years, rising CO2 in our atmosphere has led to drastic changes in our climate, resulting in worsening droughts, hurricanes, as well as floods and wildfire seasons. And so long ago, polar bears were sort of this quintessential poster child for climate change. But that paradigm is rapidly changing as the frequency and severity of climatic changes in the planet are making the environment inhospitable, not just for Arctic life, but also for human life, and especially the most vulnerable humans. So recently, The Lancet published a special series where they argued that climate change is the greatest global health threat of the 21st century. And then they kind of retracted that, like, whoa, 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 I think they scared some people out of the water. And they said, no, tackling climate change could be the greatest global health opportunity of the 21st century for the very reason that climate change transcends nearly every aspect of health. So the other reason why we as healthcare professionals need to talk about climate change is because if the global healthcare sector were a country, it would be the 5th largest emitter of greenhouse gases on the planet. So the healthcare sector, in spite of doing an incredible amount of good, has a very large carbon footprint that we need to be cognizant of. Additionally, healthcare systems are highly vulnerable to the impacts of climate-related disasters, such as hurricanes and wildfires, which in turn leads to cascading impacts on the health of those in affected communities, as well as on the functioning of the healthcare sector. Just as an overview as to where we're going today, this schematic is from the Lancet Countdown, and basically it's demonstrating how increased anthropogenic greenhouse gas emissions, so CO2 and methane, are driving climate pressures, which are things like extreme weather, increasing temperatures, rising sea levels, and extremes of precipitation, which in turn cause exposure pathways. And these are the pathways which affect health. And they include extreme heat, air pollution, water contamination, changes in vector ecology, and more. And so as we'll talk about more today, these exposures have broad impacts on health, for example, leading to respiratory disease, cardiovascular disease, and adverse birth outcomes, which we'll get to. So a theme that will come up again and again, both in this lecture and as you learn more about climate change and health, is that the changing climate affects everyone, right? So no one's immune from this, but it doesn't affect everybody equally. So first of all, the great tragedy, I think, of climate change is that those who are affected the most tend to be those who contributed least to the problem, in addition to those who have underlying health or socioeconomic vulnerabilities. And we know that around the world, women tend to be marginalized from political and economic power and have limited access to resources. And this is particularly true in conflict-affected and environmentally degraded settings. And these factors exacerbate their vulnerability to the impacts of climate change. We also know that women have underlying physiologic and cultural vulnerabilities, which can increase their risk of health impacts. So we'll go through a lot of case studies which exemplify these principles, but I just want to kind of put it out there as to where we're going today. So I really started thinking about climate change and women's health. I was working in Syria on the border of Lebanon, and I was working in a refugee camp about a year ago with the Syrian American Medical Association. And we were in the camps and we were seeing patients. And what I learned while I was there is that between 2006 and 2010, the region of Syria experienced the most severe drought in the past millennia. It turned 60% of Syria's fertile land into desert. It killed 80% of the livestock and drove 1.5 million, I would say, climate refugees into Syria's already overcrowded cities, where they collided with millions of refugees from the Iraq War. And so our patients were those displaced from this, environmental resource conflict, which they would attest to. So as one of the only female providers there, I got tasked with manning the OB-GYN tent, right? So I saw up to 50 patients per day addressing chronic and acute health needs. And it was just everything you would imagine you could see in an OB-GYN clinic, right? So prenatal care, treatment of infections, deliveries, requests for termination of pregnancy. On the other hand, people requesting help with fertility, and on and on and on. We needed a full spectrum OB-GYN service to take care of this refugee camp. And it was basically me and maybe one other provider. So it was overwhelming, to say the least. But I think even more overwhelming is the fact that this situation, and why I brought it up, is because it's a microcosm of a much larger problem which is happening worldwide. And globally, things like food scarcity, as well as water scarcity and extreme weather, are drivers of human conflict and forced migration, such as what was happening in Syria. And we know that in regions of the world with incomplete governance and underlying poverty, that climate change basically acts as a threat multiplier for civil unrest. The other thing we need to know is that globally there are over 80 million refugees currently, and 80% of them are women and girls. So the health and security needs of these women, both immediate and long-term, are enormous. So I recently pulled this data from the Global International Displacement Monitoring Center, which is an international group which carefully monitors those forced from their homes due to conflict and disasters. And this data is from 2018, and it shows that 1.3 million people were displaced just in the US alone due to conflict and natural disasters. Now, when you look globally, in 2018, there were a total of 28 million new displacements on record. And of these, 17 million were due to environmental disasters. So there's clearly a huge need to address women's health and security, given the fact that 80% of refugees are women, and we're mounting an incredible population of refugees globally annually, and the numbers are just increasing. So in 2016, ACOG, which is the American College of Obstetrics and Gynecologists, they basically came out with a policy statement where they formally recognized climate change as an urgent women's health concern. And they used pretty strong language. They stated that it threatens to widen existing gender-based health disparities and put women at elevated risk of disease, malnutrition, violence, poor mental health, lack of reproductive control, poor obstetric outcomes, and even death. And we'll get to a lot of these outcomes as we go forward. Additionally, the World Health Organization, as well as the UN, have recognized that climate change threatens to widen gender gaps in terms of physical and mental well-being. And they bring this to the forefront because of their mission to achieve the Sustainable Development Goals, to sort of narrow health gaps worldwide. And so to address these threats, we really need to understand the root causes of the disparities between men and women when faced with climate stressors. And so we'll be talking a bit about environmental side of things, as well as the physiologic and human health side of things and how they come together. So to provide some context, let's talk about disaster incidents. What we're seeing is that the incidence of disasters has been steadily increasing over the past decade. So this graph here is produced by Munich Re, and Munich Re is an insurer of insurance companies. And they monitor this stuff really closely, right? Because this affects their bottom line. And so what we notice from this graph is that the rate of geophysical events, such as earthquakes and tsunamis, that's the red at the bottom, those have remained, relatively constant over time. So it's not this that's the cause of the rise. What we see is that climate-linked disasters, such as the green and the blue, which represent hydrologic events such as floods and meteorological events such as tropical storms, are increasing, as well as these orange bars, which are called climatic events, including extreme weather, drought, and wildfire. I would argue that the green, blue, and orange are all basically climatic events, and we're seeing them on the rise. So this data is from NOAA, which is the National Oceanic and Atmospheric Administration of the US, and they culminate disaster data. And this map is showing that in 2019 alone, just in the US, we saw $14 billion climate-related disasters, including hurricanes, flooding, and drought, all with accompanying widespread impacts on human health and affecting nearly every area of the country. And when they're looking at sort of counting up how much each disaster costs, they're really looking at property damage claims. They're not even looking at the health impacts and the cost of health, which would probably blow these numbers out of the park. So let's talk about the impacts of extreme weather and how that impacts women's health. So we know that extreme weather events obviously impact everybody, but women have been found to suffer greater threats to life, longevity, as well as personal safety. So there was a recent review that was done by the World Health Organization, and they looked at the effects of natural disasters across 141 countries. And they found that on average, they kill more women than men. So for example, in 1991, when cyclones in Bangladesh killed 140,000 people, 90% of the victims were women. And in 2008, when Cyclone Nargis hit Myanmar, 61% of the 130,000 deaths were also among women. And these are extreme examples. It's not always that extreme, but these are sort of just some places to look. Additionally, female survivors of natural disasters suffer disproportionate decreases in life expectancy. So if you take a man and a woman and they experience the same natural disaster, there's toxic stress, there's physiologic changes, there's injuries, and it ultimately decreases everyone's life expectancy. But women have a disproportionate decrease in their life expectancy. They don't live as long after suffering a natural disaster. And so how and why do these disparities occur? And so research suggests that, well, first, let me step back, it's multifactorial like everything else in medicine, but some research suggests that these effects are found to be strongest in places where women have low social, economic, and political status. And we know that worldwide, women make up a larger percent of those living in extreme poverty. And so overall, they have less resources at baseline. Other data suggest that behavioral factors contribute to these disparities. For example, when women may be restricted from immediate escape during a disaster due to homebound caregiving roles for the children and the elderly. And so these sort of social roles and in turn behavioral factors can contribute. Education and language skills have also found to play a role. So for example, if public health messages are provided in a dominant language of a region, so French or English, but women didn't get access to education and only speak a minority dialect, they're not going to be able to understand evacuation instructions, warnings, public health messages, and more. And so they have a lack of access to emergent health information during disasters. Other research points to poor baseline nutritional status as well as physical health that may prevent escape and survival in the acute phase of disaster, as well as when water and food shortages ensue. So a lot of factors contribute, and the reality is that every disaster in every geographic and cultural setting is unique, and certain factors play out more than others depending on the disaster and depending on the population affected. Now, unfortunately, the disproportionate impacts go beyond mortality and life expectancy, and according to the Red Cross, women and girls are at a higher risk of physical, sexual, and intimate partner violence in the aftermath of disasters, and this is especially true in those belonging to marginalized sectors of society. And this effect has been documented worldwide, including in the US after Hurricanes Katrina and Maria. So I just pulled these headlines from some major news organizations. This stuff makes the news, but we'll see that there's some problems with really getting our brains wrapped around the data behind this. This is one study which came out of the Institute for Women's Policy Research, where they basically looked at gender-based violence in Mississippi following Hurricane Katrina. And they found that at baseline, there's about 4.6 per 100,000 people per day reported incidents of gender-based violence. And they found that in the year following Hurricane Katrina, that amount quadrupled to 16.3 per 100,000 per day. And that's the number of reported episodes of gender-based violence. And so what we're seeing is that after the hurricane, many women who were living in poverty were displaced from their homes and living in temporary shelters and trailers where they didn't have social support systems and didn't have their normal mechanisms of security. And so this is just accounting for those that were reported. So, how and why is this happening? We think, how could this possibly be happening? And so I'll just give you a case example of what was going on in Puerto Rico after Hurricane Maria. So as you're all aware, the Hurricane Maria destroyed Puerto Rico in so many ways. And one of the first things that happened is the island's entire telecommunications system went down. And even weeks after the hurricane, the 911 call centers, as well as the line to the Center for Assistance to Rape Victims, were not fully restored. So there was nowhere to call for safety. Second, key systems designed to prevent and respond to gender-based violence collapsed. So police officers, including those assigned to the Special Unit for Domestic Violence, were detailed to other tasks, such as directing traffic. Additionally, judicial tribunals responsible for handling cases of violence against women were closed, and they remained closed for months and months. So there was a total loss of legal infrastructure. Lastly, the majority of the island's 69 hospitals were without electricity or fuel for generators. So there was nowhere really to run to, and the roads were impassable, preventing victims from escaping and finding safe refuge. So there were only 4 women's shelters, which remained open on the entire island. They were working at full capacity, and this was to serve a population of nearly 4 million people. So this situation created conditions for all women where safety and legal protection were basically nearly non-existent. And this is because women's health was not prioritized. It was not built into disaster management plans, both before the hurricane as well as during the initial disaster response. And so keep in mind that this occurred in one of the most high resource settings in the world, right? So you can imagine what would happen in a place where these types of systems to protect everyone's safety are not there at baseline. So not surprisingly, women are at higher risk than men of suffering from mood disorders, such as PTSD, anxiety, and depression in the aftermath of disasters. While simultaneously, women suffer disproportionate job loss and stagnation. So for a variety of reasons, including lack of access to education and the labor sectors involved following disasters such as construction, coupled with the need to provide care for young children and elderly, women tend to be excluded from the post-disaster workforce because they either don't have the proper skills and knowledge sets, they don't have access to job training, or they're busy taking care of families. So pregnant women are especially vulnerable group to conditions during and after disasters, which we should focus on for a variety of reasons. So in the acute phase of disaster, pregnant women are high risk of trauma. And trauma is actually the leading non-obstetric cause of maternal death worldwide. And so because of physiologic and anatomic changes during pregnancy, the risk of trauma to the mother and fetus actually increases with gestational age. Additionally, it's been found that premature delivery rates are reported to increase in the 48 hours following disaster. So you have an increase in delivery just immediately following disasters. And this sets the stage for possible poor birth outcomes, right? When facilities are either closed or families are in the process of evacuation and they can't seek immediate medical care for precipitous deliveries. Now, in the weeks to months following disasters, researchers have found that women giving birth have an increased risk of complications. And these include things like preeclampsia, postpartum bleeding, low birth weight infants, and then therefore have a higher rate of cesarean section. Additionally, this research group from Tulane found that women who had post-disaster PTSD were found to suffer even higher rates of complication than those who had either less exposure or less psychological impacts from the disaster. Now, in the weeks to months following disasters, women also suffer from issues such as decreased fertility, as well as deal with the repercussions of loss of access to family planning and prenatal care. So you can imagine if you fled from the site of a disaster, you just lost access to your primary OB or your primary care doctor who was taking care of you. Now, on the other hand, if you stayed and were able to sort of weather it out, the healthcare facilities were closed. So there's this huge gap in care that occurs during disasters for women who need regular OB care. Now, this issue really came to the center stage in Houston after many clinics were closed after Hurricane Harvey and women lost access to abortion. And so really, disasters create an incredibly complex health emergency for women. And it doesn't just last days, but it lasts months, and it affects survivors, but also affects their offspring. So recognizing these risks and that this one-size-fits-all approach to disaster preparedness continuously fails to protect the health of women, ACOG came back and they put forward a list of recommendations to proactively protect women's health. So they recommend that physicians work with public health officials to identify facilities that can provide prenatal and obstetric services during a disaster. And so to support these efforts, what healthcare providers can do outside the perimeter of a disaster is be willing to accept evacuees in an effort to ensure continuity of prenatal care. They also recommend that state governments establish local facilities where prenatal care and obstetric services can be provided for those women unable to evacuate. And so said another way, obstetric care and women's health must be integral to the initial disaster response. So, when we're sending in emergency workers, we should also be sending in OB-GYNs. We should also be sending in specialized healthcare providers to take care of the population. They also recommend that clinicians encourage local and state governments to provide shelters that are safe and secure to prevent violence against women. A lot of times what happens is there just gets designated one general shelter where everybody goes, and they're mixed gendered shelters, and it's frankly just not safe for women to be there. I would also add that we need to really double down on increasing access to women's healthcare in underserved and disenfranchised areas, because by preventing vulnerability and building resilience and improving health in the present moment prevents these disastrous levels of vulnerability during emergencies. And so having contact with women who are at risk and providing them with plenty of education on an ongoing basis actually makes them more resilient during emergencies. So changing gears a little bit, something we hear about a little bit less in the media, but perhaps is equally important, is the insidious impact of climate change on infectious disease. And so what we know is that climate change is altering ecologic conditions such as humidity and temperature, which influence the distribution of diseases transmitted by vectors. So things like ticks, mosquitoes, fleas, rodents. Now, the relationship between vectors and human diseases is not linear. It's complex. It's mediated by a lot of behavioral and economic and environmental factors. However, we know that with climate change, we have a situation where permissive ecologic conditions are allowing vectors which carry human disease to expand their range into new immunonaive regions, leading to widespread impacts on health. So Lyme disease is really the textbook example of this, where we're seeing a northward as well as westward expansion of the Ixodes tick under permissive ecologic conditions, those being warmer winters and more humid summers. And this map is from the CDC. And what we're looking at is comparing the distribution of Lyme disease between 1996 and 2014. And we're seeing, where it used to just be kind of in New England, we're seeing a spreading west as well as north of the vectors. And this is a diagram representing future possible ranges of Ixodes ticks under likely scenarios of warming, where we'll see that Lyme disease could be coming all the way up into Canada as well as far west as Nebraska and Kansas. And so as healthcare providers, we need to be aware of these changing distributions of diseases, because if you trained in California and then you went to work in Nebraska, you've never really seen Lyme disease. And if you thought of Lyme disease as a disease that happens in New England, you would never think about it if someone came in with vague joint pains, right? Malaria in sub-Saharan Africa is yet another example. So what we see is that periods of unusually high rainfall altered humidity and warmer temperatures are modifying the geographic distribution and densities of Anopheles mosquitoes, leading to malaria outbreaks in previously unaffected immunonaive communities. And it also leading to increased transmission in endemic areas. So what we're seeing in this map is panel A is the current distribution and density of Anopheles mosquitoes. And B, C, and D are the future possible intensities and distributions under various different climate change scenarios. Where, D is kind of worst case scenario, we just burn every last bit of fossil fuels, where B is and C are slightly more moderated pathways. So vector-borne diseases present unique risks to women, and especially pregnant women, for both behavioral and physiologic reasons. So for example, in many parts of the world, women are the primary household members responsible for water procurement and are around standing water sources, as well as other areas that can place them in close contact with mosquito breeding sites. Pregnant women are particularly susceptible to mosquito-borne illnesses because they produce higher levels of CO2, and they also have higher skin surface temperatures because of their increased peripheral blood flow. And these two factors actually serve as chemoattractants for mosquitoes, and it increases their risk of getting bitten. Now, once infected, pregnant women also are at greater risk of manifesting more severe forms of disease. So we know that their risk of severe malaria is 3 times that of an infected non-pregnant women. And this is likely due to hormonally regulated changes to the immune system during pregnancy, which result in a higher intensity of parasitemia. Other examples include dengue virus, which is currently endemic in 100 countries and is increasing in severity and distribution in many places. It's associated with an increased risk of cesarean delivery, as well as preeclampsia, intrauterine growth restriction in pregnant women, and vertical transmission has also been documented. So that's something to keep an eye out for. Zika is another emergent climate-linked infectious disease with fetal impacts, which we all know, including microcephaly, central nervous system malformations, and impaired cognitive development. And so dengue and Zika are both transmitted by the Aedes aegypti and Aedes albopictus mosquitoes. And we know that these mosquitoes are expanding their ranges. They are very climate sensitive, and their ranges are moving higher into North America due to warmer and wetter conditions, meaning that there's the potential for transmission in the continental United States. Now, given these trends, how can we as healthcare providers protect women's health or advocate for solutions, right? So some recent work has shown that involving women in vector control activities and targeting educational campaigns towards women has actually been shown to improve women's health outcomes and decrease rates of infection. And this really demonstrates just how powerful women can be when they're provided with information to protect health. However, these types of programs, are kind of in a trial basis right now and have not been systematically incorporated into large-scale, vector control activities. But I would say, they could and should be. Now, changing gears, let's talk a bit about temperatures. I know you probably had a bit of background on this, but if this is a review, I apologize. What we know is that 16 out of the 17 hottest years since the 1980s have occurred since the year 2000. And we know that climate change affects both the mean as well as the variance in global temperatures, meaning we're seeing much more hot weather as well as an average shift in temperatures, leading to way more of these extreme heat waves. Now, in regards to human health, we know the impacts of heat illness, but the more insidious part about heat is that heat actually worsens underlying comorbidities like cardiovascular disease and respiratory disease, as well as renal failure. It's also heat is independently associated with things like interpersonal violence, as well as assault and accidental trauma, especially in the workplace. So somebody did this study where they took a tape recorder and they put it on a light post at a busy intersection, like in downtown LA during the summer. And they had a thermometer gauge. And basically they were measuring how many horn honks per minute there were. And as the temperature went up, they recorded like an increased rate of horn honking, basically kind of showing this sort of heat aggression kind of hypothesis where people get really agitated when there's more heat. And that does contribute to sort of the violence and the accidental trauma and all this stuff which happens with heat. We just don't cope well with it. Now, it's important to note that the threshold at which increases in temperature actually cause harm to an individual depend on a lot of factors, including pre-existing health conditions and acclimatization. And so heat illness is really a disease of vulnerability, right? And so for some, it doesn't really matter if it gets hot. You just, go and cool down. But for others, even small rises in temperature can have tremendous health implications, especially for the elderly and the very young and pregnant women. So physiologically, we know that heat activates inflammatory pathways, it alters coagulation cascades, and it alters CNS control of the heart, resulting in cardiovascular and cerebrovascular disease. Heat is also especially dangerous for patients taking any medications which interfere with fluid balance, such as beta blockers, diuretics, as well as those that interfere with central thermoregulatory centers, such as SSRIs and antipsychotics. So what about what happens to women and pregnant women? So heat exposure is another climate risk factor that preferentially impacts women. And studies have shown that vulnerability to heat varies by gender and geography. And in some places, women are more likely to die in heat waves. Studies have also shown an increased incidence of gestational hypertension, as well as preeclampsia during times of high temperature and low humidity. And we all know that prolonged exposure to high temperatures is independently associated with an increased risk of stillbirth, as well as certain congenital birth defects. It can be teratogenic early on. Now, cultural and socioeconomic vulnerabilities also contribute. For example, some women may suffer from poor access to healthcare and cooling facilities. There's also this, I'd say, a huge lack of awareness of women's vulnerabilities to heat among local, national, and even global decision makers. Probably due to a lack of good data, which helps us understand this phenomenon more. Other vulnerabilities are regional and cultural, including heavy clothing garments and other cultural practices, which increase risk. So what can we do to keep patients safe? You know, as healthcare providers, we get a lot of communication possibilities with I was gonna say time, but we don't get a lot of time with patients. We get a lot of communication possibilities. And what we can do is we can educate our patients. We can also work with public health and help them to make heat wave warnings that target women and target women's health. And we can also advocate for better gender disaggregated data to inform our recommendations. We can also work to innovate practice in our own communities. So this group in Ahmedabad, India found that ambient temperatures tightly correlated with the number of postpartum NICU admissions. And they worked with the hospital administration and got the delivery unit moved from like the second floor, which was the hottest floor of the hospital, to the top floor of the hospital, which had air conditioning. And once the maternal delivery unit was cool, they saw a drastic decrease in the number of NICU admissions, right? So this is an example of clinicians working in a smallish system and, you know, noticing what's going on and taking action within their own systems. So high temperatures also impact air quality, and they accelerate the formation of ground level ozone, as well as other toxic byproducts, which taken together with particulate matter result in health impacts. Now, physiologically, ozone, and this is ground level ozone, the stuff that you kind of breathe in, you know, in downtown LA, not the stuff that's up in the troposphere. But ozone and particulate matter inflame our airways when we breathe in contaminated air and can worsen chronic respiratory conditions such as COPD and asthma, but also have been found to cause permanent changes in lung tissue, as well as increase the risk of even developing asthma in young children. The other thing to worry about with ozone and particulate matter is that inhaled particles actually cross the capillary membranes, the alveolar membranes, and enter the bloodstream, where they cause injury to blood vessels, like cause inflammation, and they accelerate the development of atherosclerosis and can worsen microvascular complications of diabetes. So particulate matter and ozone, this is not new information. We've known about this for a long time, but they have profound effects on fetal and maternal health, both from direct toxin exposure, as well as vascular changes that ultimately increase the risk of poor birth outcomes, such as preterm delivery and low birth weight infants. So based on projections for poor carbon mitigation scenarios, we're looking at two different models here in the upper panel and the lower panel. I'm looking at the US. The future impacts of climate change on ozone levels and ozone-related mortality could be enormous. And so what we're seeing is kind of the first vertical panel is looking at predicted future temperatures, and then how that then in turn impacts future ozone levels and the correlation between ozone and ozone-related premature deaths. And it could be as high as $50 billion in annual lost life and livelihood by the mid-century. Now, changing gears, I want to touch on the issue of water security, which has been identified as one of the largest mediators of the health impacts of climate change in the 21st century and is particularly relevant to women's health. So over the past 20 to 30 years, we've seen an increase in the number of extreme precipitation events, which is basically when it's just like raining cats and dogs so much that it floods. And we've been seeing an increase in this over time. So I did medical school in Philadelphia, and I remember, it used to rain with these terrible rainstorms, and the city had, underground sewers, which were probably built in like, I don't know, the year 1600. And the street that I lived on would actually flood. And it was disgusting because you could see all the oil and all the nasty, like toxic stuff washed down into the Schuylkill River, which then was reclaimed for like drinking water, like a mile downstream, right? And so these heavy precipitation events, when they happen, they wash a lot of stuff into reservoirs, into rivers, including agricultural waste and all types of stuff. And they end up getting into drinking water supplies, even in places that have really good water infrastructure. And so there are studies showing that when after extreme precipitation events, that we see spikes in utilization of healthcare due to gastrointestinal illness. And so when this happens in the US, obviously it's bad. But if you think about it, when this happens in parts of the world with already very poor urban planning and sanitation services, as well as poor healthcare systems, the impacts, are devastating. So on the one hand, we're seeing extreme precipitation and flooding and issues related to that. However, simultaneously, we're seeing areas of the world that are experiencing more frequent and prolonged drought. So it's this really weird, mismatch of where the precipitation's happening globally. And this is happening, due to changing climate patterns. Now, today, there's roughly 800 million, or 1 in 9 people, who lack access to safe, reliable drinking water, and 2 billion people, so 1 in 3, who lack access to sanitation. And of course, the majority of these people are living in extreme poverty. And as we mentioned, the majority of those living in extreme poverty are women. So it's relevant. And we know that water scarcity is a threat to women's health and well-being. And this is because women and girls are, for social reasons, responsible for fetching water in 4 out of 5 households where drinking water is not on premises. So where you have to go either to a local well, or you have to go to a local river, but a place that's not like just in your house. Women are the ones who take on this job. And so when there's drought or when there's water insecurity, that duty falls on women. And so instead of pursuing an education or pursuing other activities that result in economic gain, women will be spending time gathering water. And so it's estimated that during the dry season in water-stressed areas, 30% or more of a woman's daily energy expenditure is spent harvesting water. So for example, a family of 5 needs a minimum of 100 liters of water per day. And this must sometimes be carried 2 to 5 kilometers. So you're spending half your day basically carrying water. And as climate change decreases the availability of clean water, in many places, women stand to be further locked into cycles of poverty because of their marriage to this role in providing water, and doing that instead of getting an education or working where they're getting paid. Now, additionally, water harvesting places women and female children at risk for a lot of musculoskeletal issues, including cumulative damage to the spine and neck. And it also increases exposure to heat stress, right? As well as infections from poor water sources and exposure to unsafe areas. And so this is a picture of a woman gathering water for crop irrigation in Burkina Faso, where there's a severe water crisis. Now, the impacts of drought and flooding also pose serious risks to the 2.1 billion people who lack access to sanitation. So we know that women and girls are affected disproportionately due to periods of increased vulnerability to infection around menstruation and reproduction. Additionally, it's been found that lack of access to sanitation is associated with gender-based violence and increased psychological stress and trauma among women and girls who are forced to openly defecate or walk to shared sanitation facilities. It's just an incredibly destructive and, frankly, inhumane way to live. Research points to a strong association between low access to sanitation facilities and adverse pregnancy outcomes, even after controlling for socio-demographic and clinical factors. Now, although significant progress has been made over the past decade to improve access to clean water, sustained progress is tenuous with climate pressures, and we really need proactive solutions. And it's been found that involvement of women in water, sanitation, and hygiene decision-making and governance has been found to be a significant predictor of functional water systems as well as sustainable water systems. And this has been documented all over the world. where if you involve women in deciding, where should we put the well or where should we put the facilities, they tend to be better taken care of, and they remain functional for longer, and it improves the health of not just women in the community, but everybody in the community. Another strategy is using smart models, right? So the World Bank has a lot of efforts going on where they're identifying what they call geographic hotspots or climate hotspots, where if there's going to be a drought in northern Madagascar within the next 30 years, you start pre-positioning good water infrastructure now to prevent vulnerability. So you're not faced with this thing where you're trying to catch up with all this unprecedented levels of poverty and vulnerability. Now, food security is closely linked to water security, and models predict that by 2050, the developing world will need to increase production by roughly 77% to feed its growing populations. We know that heat waves, as well as prolonged drought and heavy flooding, threaten to undermine this increased need in production. And women are highly inherently sensitive to food insecurity due to increased nutritional needs during lactation and pregnancy. Additionally, globally, women make up 80% of those living under $2 a day, and in general are more nutrient deficient than men. Women also produce 60 to 80% of all the food in low-income countries, and thus their health as well as their livelihoods are at risk from climate-related changes like drought and heat waves and flooding. Now, although women produce the majority of the food, less than 2% are landowners, and of that small percentage, less than 1% have crop insurance. So there's this huge underlying disparity where women don't have access to legal rights or any other type of administrative business rights in many parts of the world. So it's been found that training women in climate resilient farming models is an intervention to improve not just women's health, but also community health and resilience. And this has been demonstrated through models in Maharashtra, India, where there's been successive years of drought. And this nonprofit SSP went in and interviewed a lot of women and found that, although they're really involved in the farming, the decisions related to crop selection rest exclusively with the male counterparts. And so women, although they would prefer to grow things like vegetables that you can eat, men were committed to growing single-strain cash crops like soya, cotton, and sugarcane, which come with expensive chemical inputs as well as are very drought sensitive. And so this group SSP initiated this women-centered climate resilient farming model where you reposition women as decision makers and encourage them to form co-ops to purchase land or to take a small parcel of their family land to start to cultivate food crops. And there's just tons of training sessions that go into this where women are getting trained on how to do proper crop rotation, how to pick drought resistant crops. And so there's this huge network which has sprouted up in this region. And so far the group has trained 170,000 grassroots women entrepreneurs, farmers, and community leaders. And so this is a really incredible situation where just providing education and assisting with community gatherings, sort of serving as like, a nucleus for events has really changed this region. So we're nearing the end of the hour, and just to kind of summarize what we've been talking about, what we've seen is that climate vulnerability translates to issues of social justice and gender inequality. And we know that women suffer greater susceptibility, greater exposure to climate hazards, and are less able to cope with and recover from damages, which results in disproportionate losses in health and assets and further widens social and health inequalities. It all sounds really down, but the other side of this is that simultaneously, women's social roles and potential for agency afford so many opportunities for promoting solutions. And so there's just an incredible amount that we can gain by focusing on women's health. And so just some thoughts moving forward. On a high level, what we need to do, I believe, is incorporate comprehensive strategies which integrate gender vulnerability into climate adaptation and mitigation planning, right? And so when we're thinking about investments in these huge large-scale water projects or sanitation projects or flood mitigation or healthcare infrastructure, we need to have women in the room helping to make decisions, and not just like the token one woman. Like, you need multiple women in the room to make decisions. We must also take proactive steps to develop and protect women's healthcare access, especially in high-risk areas. And that's something, we will all play a role in as we practice as clinicians. And as physicians, we can also use our voices and work with government and public health agencies to take steps to ensure the protection of women's health services and human rights, especially in disaster scenarios. And that could be something as simple as getting involved with your hospital's disaster planning committee, right? There's a committee that they have to have a committee. They meet once a year, like, can you join that committee, right? We can also work with government and public health agencies to take steps to ensure the protection of women's health and human rights. Did I just say that? And sorry, we can also, advocate for gender-sensitive research, including the collection, analysis, and reporting of gender disaggregated data. Because right now, a lot of the data that we get comes in sort of in lump sum in terms of mortality statistics and health statistics, and we generally don't know the percentage of men and women with the conditions that are being studied. So lots of stuff there. Thanks everyone for your attention, and thanks for tuning in today. This is my contact information. We have a book coming out at the end of this year. It's called Global Climate Change and Human Health. It will be the second edition, and you can find it online. So thanks everyone for your attention, and I'm happy to stick around for some questions.
Thank you, Dr. Sorensen. That was amazing. That was a wonderful lecture. And I am so impressed with just the huge evidence base that you presented to students and those recommendations for what they can do as they move forward in their careers at the end. I'm going to open it up to Kajan to collate the questions that she's received, and we'll go, if you're willing, we can go all the way till 2 o'clock.
Sure.
Okay, so our first question is from Emily from Emory. She has two questions. First one is, what are the rates of postpartum depression and psychosis amongst new mothers following disasters? And how do you think this will play out during the period after COVID-19?
Oh, wow, that's a great question. The rates of postpartum depression and psychosis, I don't think I've actually seen a good study looking at that. And one of the biggest problems we have, Emily, honestly, is that when we do see statistics coming out after disasters related to women's health, they're very isolated. It'll be like, rates of depression in women after Hurricane Katrina. And you have this convenient sample of people who happen to be in one shelter, right? And so we don't have large scale information. No one's done the research, right, to really answer that question. So I don't know if there's an answer. I'll look into it and try to get back to you. But what the problem is with this line of research is that you have a lot of small case studies, like 200 women after this disaster, we found this. But that's just like one tiny little geographic area. We have no way of making generalizations at this point. So there's a huge amount of information that's lacking. The question was, how will this affect women after COVID-19? I think that's a fascinating question. I don't even know where to begin to speculate in terms of how women's health is being affected. You could look at sort of women in areas where they already had poor access to healthcare. I'm sure that's gotten worse. If you don't have a good streaming internet connection at home, how are you going to have a telemedicine visit, right? So that's going to impact women, especially those who have less resources. And then, you can look at the issues of violence towards women. Are we seeing more of that because people are trapped at home? I know I've talked to a lot of school teachers who are really concerned about their at-risk students who come from homes that have a lot of violence in them because, school's a refuge for kids, and, it's their chance to be out of a home. And so, if homes have any violence at baseline or any drug abuse or any alcohol abuse, they're going to be at higher risk of having violence if everyone's trapped in the home. So I don't know. What do you think?
Me or the person
asking? Yeah. I think there's so much we can speculate. I don't know. This is a situation I think we've never quite dealt with, in the world. It's really unique. So
I know, as a pediatrician, we have our audience on mute, so they can definitely respond through the chat if you have thoughts for Dr. Sorensen's questions. As a pediatrician here at Emory, I certainly share that concern that school teachers have about our patients who are at home and those who are not able to come into us. Teachers are often a screening tool for violence that may be happening to kids in the home, and that system is just not existing now. So we are worried about our kids, and schools also a safe place for kids in terms of just having meals to eat. A lot of kids depend on school for 2 meals a day. And while there have been a lot of cities who have come up with systems to put something in place to get food to children, it's not the same as them being there at school. And that's even irregardless of the educational concerns too.
Yeah. Yeah. So yeah, there's a lot of information. Hopefully we'll get soon, because this type of pandemic could happen again, and, hopefully next time we can be a little bit more prepared.
Okay, next question comes from Samantha from the University of Nebraska. Are there any organizations advocating for similar measures for transgender individuals? Often trans issues are lumped in with women's issues when the needs are not the same.
That's a really, really great point. And I should have touched on that more. I guess my background isn't I don't know enough to really talk from an expert perspective on it. I know that in some of the reading I come across, as you said, it's often lumped in with women's health issues. So I have come across some of this information. I know that organizations like the Red Cross, when they produce their reports looking at gender-based violence, they also look at violence towards trans and towards bisexual. And so it does get lumped in, and I think people are trying to look at it. And I would say that the data is probably even more sparse, as I'm sure everyone is aware of what goes on. We need more data. We need more information. We need disaggregated data, right? We need to be able to look at this so we can address numbers. And so, yeah, I think, the larger organizations have these issues on their radar, and they try to find information. But again, it's really sparse. But if you're interested, I'm happy to send you some stuff out of, I know the Red Cross has looked at this, and I think the World Health Organization might touch on it in some of their reports as well.
Megan from the University of Massachusetts asks, what are your thoughts on how to effectively partner with women in developing countries to promote climate resilience without stepping into paternalism or pushing Western belief systems?
I think that's a really great, point. And, yeah, it's tough, right? What I found to be the most effective thing to do is to work with healthcare providers in developing parts of the world, right? So, when you go to a place, when you go into a humanitarian crisis situation, or you go into a community, I try not to see patients, right? I try to work with nurses. I try to work with other doctors. I try to work with other staff, other community members, and train them, have an open dialogue about, the situation with them, rather than sort of getting to this position of sounding preachy. I also, I think that you get more, bang for your buck by actually working, with people who have decisional capacity more so than working directly with, with patients. I think, working within systems, working within public health departments is probably a better place for us to be inserting these types of frameworks about how to become more resilient, so working with a hospital association versus working directly with the patient, if that makes more sense. I think there's just more opportunity for movement innovation, and also more receptivity and more possibility to do something with it, right? Because I think a lot of times, you're talking to a patient and, you're like, what can you tell them to do anything different, right? Like they're doing the best they can, their water situation is what it is, right? You can say you need to drink better water, but it's a lot easier to say, let's work with a community group and figure out what are the barriers to getting piped water into this situation, right? So I think, taking our expertise and working within systems is a lot more effective than directly working with patients.
So Emmeline from Emory asks that you mentioned the need for better research and how often there is only small case studies to gain insight based on emergencies. So, for example, mood disorders. This theme, I imagine, extends beyond to research in any emergency settings, especially in the event we want more granular, disaggregated data as shared. Might you have any suggestions for this as to how we can improve research in this setting while also using it as an opportunity to build capacity in healthcare and science training in respective communities?
Yeah, that's a really great question and really great point. And, you know, I think there are some groups. So, for example, like the Global Burden of Disease group, where they're based out of University of Washington, and they are this large organization funded by the Gates Foundation, which is looking at mortality and is looking at disease, in every country and using every possible way to get data out of countries. I think that these types of large initiatives, they need large amounts of funding, right? Funding's always the problem, right? And so I think that's something positive that's going in the right direction. In terms of building capacity at a country level, especially a low middle income country level, I think there's two parts to that, right? There's like having the political will to do it, like the country has to want to do it, and then there has to be the expertise. And so I know there's funding opportunities, through NIH, where you have to have, a member of a low middle income country and a member of, a high income country working together on a data project, on an initiative project. And so that allows for this transmission of knowledge from expert to expert. And so you're actually building capacity. I think a lot of issues come up with that in terms of, who owns the data, right? So if you have the scientific project, who ends up owning it? But my experience with this is that there is that cognizance among researchers who work in the international space that building capacity is what we need to do. Like there's no glory in doing, international work. Like the point is we need to build capacity. In terms of gathering data, I've seen some really cool stuff going on in Maharashtra, India, where the public health department is basically giving their healthcare workers, so these are, they've got this troop of like 20,000 women who go out into communities and gather health data, right? They'll go out like once a week to a place and say, how many people have had diarrhea in this village? How many people have had fever? And they're putting the data directly into like a cell phone app. And so the data is getting immediately displayed and sent back to the capital. And so we're now able to sort of use technology to gather data on places like remote rural places where there's very high need and transmit that data back very quickly to get more information. So, I think we're going to be seeing, more data coming forward in the future. And I think, wherever you are in the process of looking at data and publishing and, or being a researcher yourself, looking at how to make that widely available, I think, and open access, I think is a goal we need to strive for.
Okay, due to time, this one will be our last question. So Ben from Emory asked, heat stress nephropathy research has primarily been described in male farmers in Central America and South Asia. Is there data yet on the disease's impact on female farmers and outdoor laborers? And are male farmers truly at greater risk, or does this represent a sampling bias?
That's a super great question. So, there's a lot of different answers to this. So is there a sampling bias? So the populations that we study tend to be laborers in really high intense agricultural settings, like sugarcane, right? Where men are out there cutting, 6 tons of sugarcane a day. Mostly it's men in this group, but not always. So we tend to capture like 5% of our cohorts are women. And there's just not as much data about women. And I think that's a selection bias because we're looking at a profession, at a field where it's mostly men there inherently. However, there's been some community level studies where, we're not looking at workers. We're just going into a community where we know that there's risk for, Mesoamerican nephropathy or chronic kidney disease of unknown origin. And we are finding it in women, and we're finding it in children as young as in their adolescence. And so more of that data is emerging. But again, you're right, it's not focused on women. we're looking at the impact of the male workers. Now, interestingly, some studies have come out of California where women were captured in this sort of convenient sample of workers. The study was really looking at what happens to people's kidney health if they're paid a salary, so you get, whatever, $100 a day, or if they're paid piecemeal. Piecemeal meaning based on how much, whatever unit of product you cut or pick. And what they found is that if people are paid a salary, they tend to have better kidney function because they're not out there, basically sacrificing their bodies to make money. If you pay people piecemeal, kidney function is worse for men. It's also worse for women, but it's way worse for women. So when women go out and they're being paid piecemeal, they tend to kill their kidneys much faster than men do. And I don't know why that is. I don't know what that has to do with. Women just tend to sacrifice their kidneys faster than men do, faced with the same, really difficult situation of like, you only get paid by what you harvest. And so, we do find the data related to women. It's just like picking it out of these larger data sets where we're mostly looking at men. So there's a lot of need to look at it.
Thank you, everybody, for your questions, and thank you for your answers.
Yeah, and thank you, Kajan, for fielding those. I think there was one more question that we'll send you in a follow-up email, Dr. Sorensen, because we're already after 2 p.m. Please, everyone, join me in clapping for Dr. Sorensen. That was just an amazing lecture, and I really appreciated at the end all the very thoughtful student questions and your responses that show them some areas for future research that they can be involved with as we move forward and they're planning their careers. So thank you, everyone. Our next lecture will be tomorrow, and I will send information for that, the Zoom link and the password in a couple hours after our small group meeting here at Emory. So thank you, Dr. Sorensen. We're so grateful to have you and really appreciate you.
Thanks, everyone. Have a great